Hello, my name is Dr. Snyder, and I'm an orthopedic surgeon at the Southern California Orthopedic Institute in Van Nuys, California. We're located in the San Fernando Valley on the north side of Los Angeles, California. I've been practicing with the SCOE group since completing my orthopedic training at USC 33 years ago. I chose to specialize in arthroscopic surgery of the shoulder after first viewing the exquisite anatomy of the shoulder joint in 1982, and that's when I fell in love with this special part of the anatomy. In this video, I will be discussing my perspective on the arthroscopic dislocation and management opportunities that the arthroscope offers us for repairing this very serious injury to the shoulder. There are several kinds of shoulder dislocations. The common event in all dislocations is that the head or ball of the upper arm bone, the humerus, is knocked out of the socket or cup formed by the scapula at the shoulder joint. When this happens, of course, there is severe damage to the ligaments and sometimes even the rotator cuff that are supposed to hold the bones in normal alignment. Additionally, in many cases of dislocation trauma, there will be a fracture to the bones of the ball or socket, thus complicating the injury. Shoulder dislocations occur most commonly after a violent fall or sports-related injury in which the shoulder is jammed or twisted beyond the normal motion. In most cases, the humeral head is displaced in the front of the shoulder socket, an anterior dislocation, although it can also occur in the posterior direction, going out behind the socket. Of course, when the shoulder dislocates, pain is the primary symptom. With the ball out of the socket, it is impossible to rotate the shoulder, and thus there's a severe lack of mobility of the arm. There may be bruising, swelling, numbness, and the arm may appear to be hanging low below the shoulder. Treatment of a dislocated shoulder is naturally to get the shoulder back in place as soon as possible. If there is competent medical help available, then it may be possible to apply very careful traction to the arm in the direction that it is resting to pull the ball away from the socket, allowing it to move back over the edge of the joint and back into place. It should not be forced or twisted because if there is a fracture to the bone, it may be worsened. Most often the patient will need to be taken to an emergency room for a reduction, often after being given an anesthetic or a muscle relaxing medicine. Once the shoulder is back in place, it can be treated with a sling to rest the shoulder and allow the torn tissues to heal as much as possible. The prognosis for healing depends on the age of the patient at the time of the first dislocation. In young, active patients who have a traumatic shoulder dislocation, there's a high chance that they will have a chronically loose shoulder and redislocate when they resume activities, especially sports. Middle-aged patients have much less chance of repeat dislocations following healing, while older patients are at high risk of having a rotator cuff tear or a significant humeral fracture associated with their dislocation. All patients who dislocate their shoulder should have x-rays and often an MRI scan to assess the damage of the joint. If the glenoid bone is significantly broken or the rotator cuff torn, they most often need to be repaired. Sometimes, if the MRI shows that the ligaments that normally hold the shoulder in the joint are badly torn along with the labrum, that is the attachment site, they will need to be repaired as well. It is possible to repair these tissues using open surgical techniques, but in my practice in the last 25 plus years, I've only done this with arthroscopic repair. Any active, healthy patient who has a recurrent shoulder dislocation should consider having a repair if the disability of the instability is significantly affecting their life or causing them to avoid desired activities. Young people, especially, have a lifetime ahead of them that will require overhead use of the arms for work and sporting activities. Older patients who suffer a torn rotator cuff with the dislocation should also consider repair if their pain and disability are unacceptable for their chosen lifestyle. The arthroscopic surgical repair for a shoulder dislocation is performed at COSI. COSY is the outpatient surgical center on the 4th floor of our office building here in Van Nuys. The patient is given a general anesthetic, and 3 1/4-inch holes or portals are placed around the shoulder joint. The arthroscope, the telescope with a video camera attached, is inserted into the joint, and then the joint is distended with surgical fluid. There are 3 rubber tubes inserted, one into each one of the portals, and the operating tools are inserted through these little tubes and used to clean up and repair the torn tissues. And the ligaments are reattached to the bone. This reattachment is performed using a special suture anchor, which is made of strong fabric material that is passed through drill holes in the bone in the area that the ligament should be reattached. Once the anchor is tightly fixed on the edge of the shoulder socket, the sutures are passed through the torn labrum and ligaments and then tied together to fix the labral tissues back in the normal position for healing. Usually 2 or 3 of these anchors are needed for the complete repair. The recovery process is divided into 3 phases or steps. The first 5 weeks postoperatively, the patient is protected in a special ultrasling brace. This is a very safe and comfortable shoulder immobilizer that holds the arm in the ideal position for healing, which is a little bit of external rotation and slight abduction. The sling should be worn at all times when the patient is up and around, especially when going outside, shopping, or in a group such as at school. It should also be worn at night. It is certainly allowable to remove the sling while sitting to do computer work, to watch TV, read, eat, drive, or shower. After 5 weeks, the ultrasling is removed and physical therapy begins. The usual course is 8 to 10 weeks at 2 to 3 times a week, but sometimes a few more weeks are needed, especially in older patients with stiffness or weakness. The final phase of the return to full activity is allowed after 6 months. Some patients who play vigorous sports may wish to wear an activity brace for a few months after their final physical therapy. As with everything in medicine and life, there's no single treatment that fits all cases of shoulder dislocation. Some cases, even in young athletes, may heal with simple rest, although the chance of that happening is not very high. If there is a second dislocation, it is likely that the ligaments are detached, and often the bone is fractured, and the chance of recurrence is high. The decision to have a dislocated shoulder repaired is unique to each person, and we will do our best to help you to make the appropriate decision for your shoulder or that of your loved one. I sincerely hope that this short introduction to shoulder instability helps you to understand my approach to this very common problem. I am proud that we here at SCOE have been in the forefront of development of shoulder arthroscopy and certainly instability repair. We have helped with the design and testing of many of the tools used to perform these delicate repairs, including the suture anchors, stitchers, dressings, slings, and other tools. Shoulder arthroscopy is our passion, and we hope it helps you get back to normal, active, enjoyable life. To learn more about arthroscopic shoulder dislocations and their repair, please visit our website at www.scoe.com. And thank you very much.